Hello and welcome back to the Friendly Pharmacy 5 channel. My name is Lindsay Dixon. I am a pharmacist and the host of the channel. Today we will be having a conversation with a pharmacist who specializes in women's health, in particular menopause. Now, menopause has been having quite a moment in the media lately, and there remains a lot of confusion and misinformation, maybe even some controversy, even amongst healthcare professionals in regards to menopause and treatments for menopause. So, in this conversation, Teresa is going to shed some light on why there has been so much confusion, where this has stemmed from, and what the evidence today is for these treatments. What options should women be looking into? What are the signs and symptoms of perimenopause as well as menopause? And what are some good resources for information for women who would like to know more? I know that this has been a very frustrating and sometimes a very difficult transition for women, especially when they consult with their healthcare provider and sometimes they are given conflicting advice. So, this is the first of a series of conversations that I want to have to try to clear up this confusion and allow women to have a better understanding and be able to advocate better for themselves and for their health when it comes to these issues. I think you'll really enjoy what Teresa has to say. She's very well informed and she's been working in this area for quite a long time. If you have any questions that come out of this interview or you would like to submit a comment, please do so, as I always read the comments. I'm always engaging in the comment section, and often the questions that you have are questions that other people have as well, and we can address those in a future episode. So with all of that being said, let's dive right into our conversation with today's guest, Teresa Isabel Dias. Hello and welcome to Friendly Pharmacy 5. I have a very special guest with me. Teresa Isabel Dias specializes in women's health and particularly in the area of menopause. We have a lot to discuss on this topic today, but first, Teresa, thank you so much for joining me today from Toronto, Canada.
Thank you for having me and for talking about menopause.
Yeah, this is such an important topic, and I think that it's becoming something that we can talk about more. This topic of menopause seems to be getting a lot of attention in the media. But could you tell us, I know that you've been in the media as well, could you tell us how you got into this area as a pharmacist, how you ended up specializing in the area of menopause?
So when I was in my late 40s, my son asked me if I was bipolar because apparently my mood swings were extreme. So since I was the healthcare professional of the family, it was upon me to find out why was I behaving like that. So I found out that I was in perimenopause. I found great information that professionals and health professionals and women alike can go online and visit the North American Menopause Society's website. It has very good evidence-based, up-to-date information. So I learned about what was going on in my body, and then I discovered that I could become a certified menopause practitioner through NAMS. So I studied for a year because brain fog and memory issues and difficulty with concentrating is very common in perimenopause. So I knew that I was reading one paragraph 1, 2, 3 times and I could not retain any information. So I gave myself a year to prepare for the exam, and then I became a certified menopause practitioner in November 2013.
Wow, that's amazing. And when you did the certification, I mean, you were already a pharmacist. Was it frustrating for you that you didn't already know what to do, or what kind of barriers did you face yourself?
Yes, it was. And in those days, I was a pharmacist working in a community when the results of the WHI trial came out. And I had a patient who literally threw estrogen pills down the toilet, a hole of no-nos right there. And she came to me a few days later, pulling her hair out and very frustrated, very tired, that she couldn't sleep. She had hot flashes. And she asked me, um, Now that they say this is going to be bad for me, what do I take? I don't know. We weren't given any options after that, right? So it's been a big struggle to take care of women, for healthcare professionals and for women themselves, since the WHI trial results came out. But it's getting better. There's more awareness. We'll talk about that.
Yeah, so that Women's Health Initiative trial, can you, for those who don't know, can you explain a little bit about that? Because that's where a lot of this confusion comes from, and even misinformation. So, could you tell us when that happened and what kind of came out of that?
I believe it was 2002 that the results came out, and there were menopause. Those days was called hormone replacement therapy. Now we call it menopause hormone therapy, because we're not replacing any hormones. We're just adding a little bit to relieve symptoms. But in those days, the purpose of the trial, which enrolled thousands and thousands of women, was to see if hormone therapy could prevent disease. So the intention was not to see if it could decrease hot flashes, vasomotor symptoms, night sweats, if it could improve the symptoms of women struggling with menopause. It was to see if it would prevent disease. And they enroll women from 50 some years to 70 something. So the average age of the women enrolled in the trial was way over the average age of menopause. So the average age is 51. And I believe the average age of women enrolled was over 60. So many of them had not had estrogen in their systems for years, for decades. So when they were introduced to estrogen again, and because of their age being more, the risks for certain diseases being higher with the increased age and so on, they discovered that the hormone therapy they used increased risk of strokes, cardiovascular events like heart attacks, and also increased the risk of breast cancer. And of course, when the scientists cannot explain the risks in terms of what is your personal risk, because my risk is different from yours and is different from a cohort of women. So explaining risk is very important for women to understand what is my risk of taking this, considering my health status and my health history. So they didn't explain that properly. So everybody ran away with, hormone therapy causes increase of this and that and that and that. I don't want to take it. And the doctors say, I don't want to prescribe it. So since then, we've been fighting for ways of decreasing symptoms of menopause. So women have been taking all kinds of things that are not evidence-based, that are not well-studied, that are not proven safe or effective. But when you don't have options and you're suffering, you take whatever you read on Google about that you think might help.
Yeah, and I think that's a really important point that you make, is that by removing the hormone replacement therapy, other things came to substitute this, and things like you said that weren't studied, things that can have their own problems, right? And women were just kind of left to their own devices. And I think that's even the case now. Do you think there's enough education even among healthcare professionals in today's day about this topic?
That is, and it's nobody's fault, because the doctors do not have education through the medical school about menopause. So we can't expect them to all of a sudden know everything. So someone like me with a particular interest in menopause can study further and become a certified menopause practitioner. So can nurses and anyone with a healthcare degree. But we know doctors are busy, and the family physician has to know so much about so many things. And if it keeps coming at you, different information from this and that and contradictory information, what you do? Usually you stay away from it so you don't get into trouble and don't harm anyone. So it's been the case that doctors are not well educated about menopause management.
Can you give us maybe just some definitions of perimenopause? What is perimenopause? What is menopause? And then also, at what ages can women experience this? And, maybe some of the signs and symptoms of these transitions.
Sure. So average age of menopause in North America is 51. And menopause is not a one thing that happens overnight. It's a continuum. So it's a menopause transition. Menopause definition is no more periods, no more menstrual periods, no more ovulation. When you don't ovulate anymore, you're said to be in menopause. And it's a diagnosis in retrospect. So after 12 months or no periods, you're said to be in menopause. After that, you are in postmenopause. But as a continuum, your body gets used to having fluctuating hormone levels, estrogen levels and progesterone levels, which are the main two female hormones, sexual hormones. So perimenopause can last 3, 6, 10 years and may start in a woman's late 30s or early 40s. Because if you say that average age is 51 and menopause tends to happen between 45 and 55, if you are hit menopause at 45 and you had 8 years of perimenopause, you're starting in late 30s. And no one is thinking about perimenopause in their late 30s. Some women are still having babies, and some women get into perimenopause after a birth in their late 30s, and nothing goes back to the way it was, and it's confusing and it's worrisome. So perimenopause are the years leading up to menopause, when things start changing in the body and you feel different. Then menopause is the end of periods, confirmed after 12 months, and you in postmenopause for the rest of your life.
That's amazing. So even women in their late 30s could be starting to experience some symptoms of perimenopause. And I really doubt that women know what to look for. What could be some of the signs and symptoms that you might be in perimenopause?
So usually the first change is in periods. So some women start having periods closer together or further apart. They may become heavier, they may become lighter, they may become, you may have spotting in between periods. So a change in menstrual period is usually the first sign that you are in perimenopause, that your ovaries are aging and eventually will shut down in menopause. But other women can experience, and usually they say there's 30-something symptoms of menopause if you Google it.
Wow.
You're not going to have them all at the same time, and it changes. So expect the unexpected, ride the wave, and don't get too upset about it, because it too shall pass. But if you experience hot flashes and night sweats, if you experience hair loss or weight gain, we can't blame everything or every symptom in menopause. So it's important that women keep up their doctor's visits and do their blood tests to rule out other medical conditions that can be giving them similar symptoms. So low iron, anemia, or hypothyroidism, or the medical conditions that may have symptoms similar should be ruled out before they assume, oh, this is fine, I'm just going through perimenopause. So have a checkup, check with your doctor, connect the dots, and if you don't feel right, check it out. And then if everything is fine, you probably are in perimenopause and things change. So hot flashes affect 80% of women. Some of them have terrible night sweats. They soak through their pajamas. They need to change clothes at night. Brain fog, which is concentration problems or retaining memory issues, not remembering your kids' names, not remembering a word. It's whatchamacallit phase of life, because you always trying to remember what you're trying to say. Fatigue is very, very common. Some women have a lot of aches and pains. And in that case, I say check with your doctor, because rheumatoid arthritis or some other medical condition may cause those aches and pains, and we need to rule that out. But it's very common also to have itchy, dry skin, falling hair, whatever we wanted, and growing in places we don't want it. So it's a wide range of symptoms because there are estrogen receptors in everywhere in a woman's body.
That's a great explanation, and you talked about a lot of those symptoms. I wanted to go back a little bit to brain health and memory because a lot of women seem to struggle with this and they don't necessarily recognize it. So that's a very important point to get checked out and make sure that this isn't being caused by something else. But when we speak specifically about perimenopause and menopause and the brain, could you explain why menopause affects our brain? Is it the lack of estrogen, or where does this stem from?
So there's interesting research going on now. This is a new field in menopause. There's a neurologist in the East Coast of the United States studying the effect of estrogen in the brain. As I said, there are estrogen receptors, places where estrogen acts in all cells almost of our body, the skin, the brain, everywhere. So in the brain, when estrogen starts fluctuating, there seems to be an effect on our cognition, our memory, and our concentration and all that, more due to the steep decline of estrogen rather than the lack of estrogen. Because in postmenopause, when estrogen levels are low but stable, women seem to feel better cognitively speaking. So I had lots of brain fog in perimenopause, but thank goodness it got much better in postmenopause. And it can be very scary because you don't know what's going on. So everybody thinks, I have dementia, oh my goodness. So it seems to be that it is the rapid decrease in levels of estrogen during perimenopause that cause most of the cognition symptoms women complain about.
Wow, that's fascinating. I'm going to look up that.
I'm waiting excitedly for the more news about this.
Yeah, that's incredibly interesting. And a lot of women also complain around this age that they have a lot of difficulty losing weight, or they gain weight during this transition. So, what is causing that?
A lot of factors. So one of the most fascinating things is that even the chemical composition of fat changes in menopause. And where we store it also changes. We get a man-like body. So we start accumulating fat in the middle. So if we had an hourglass shape before, now that waist is going to widen. And so in all the factors together are, if you think of all the factors that come at this time, it's very easy why we put on weight, and even those who don't put on weight change shape. So as I said, fat accumulates around the middle. You're so fatigued that looking at your gym clothes alone makes you tired, never mind picking them up, putting them on, and go to the gym. And also we start losing a lot of muscle mass.
Yes.
And the more muscle you have, the higher your metabolism, the more you burn fat without doing anything. So if you and I are the same weight, and you are young and have more muscle than I do, you have a higher metabolism and you're going to burn more fat during this interview than I do. So I tend to put on more weight. So a woman's best friend after estrogen is muscle. That's why we should encourage women to do weight-bearing exercises to keep our muscles, so it increases our metabolism and avoids weight gain. And then if we don't do all those things and we continue exercising and eating while we were doing before menopause, it's going to increase, the weight is going to increase because of all those factors.
And the weight bearing exercise is so important. I feel like there's not enough attention paid to this because estrogen also impacts our bones, right? And so if we have good muscle mass and if we're paying attention to that, that helps to strengthen, right, and support our bones. What would you have to say to women about the importance of bone health when it comes to going through this transition?
So it's very important for women to be aware of their risk of osteoporosis, because bone, as you know, it's an active thing. So we make and lose bone constantly, but after our 30s, we start losing more than we make. And this decline of bone building increases in speed after menopause. So we lose a lot more, we lose bone a lot faster the 5 years after menopause than we do afterwards. So it's very important that we know that. That's why awareness and education early before you become post-menopause is so important, because there are a lot of things you can do to have a good bone mass to start with before you start losing it around menopause. So as you said, bone-friendly exercises like weight-gaining exercises, walking or running, or something that has an impact on your body that's going to prevent a loss of bone, and also taking vitamin D and enough calcium. All those things are very good for bone health to prevent this, or to slow down the rate at which we're going to lose bone around menopause.
Yeah, those are really important points. And so if people are aware of that before they even go through this transition, or when they're early on in it, they can definitely try to preserve some of that muscle mass and bone, right? As they go through this. So we've talked a little bit about the symptoms and about some of the things that we can do to try to mitigate any damage caused by this I guess lack of estrogen. But as for treatments, hormone replacement therapy, where do we stand with that, with the information that we have today?
So the most effective treatment for menopause symptoms still is menopause hormone therapy, also known as hormone replacement therapy. And as we said at the beginning, there's a lot of fear about this. So that's the most effective treatment. It's not for everyone, and it shouldn't be taken for other reasons, or let's say it's only approved for the treatment of moderate to severe menopause symptoms. So we don't take it to prevent wrinkles or hair loss or anything. In some countries, I believe including Canada, it's also can also be prescribed to prevent osteoporosis that is otherwise not treated properly for some reason. So hormone therapy is still the most effective treatment, but as I said, not everyone is a good candidate for it. We have a cohort of women in this country that are particularly underserved in menopause relief. And I'm talking about the breast cancer survivors, because most of them are not supposed to take hormone therapy. So for those women, there are non-hormone treatments that can be helpful to relieve the symptoms. But with hormone therapy, you also prevent osteoporosis, so you prevent bone loss. If it's initiated between the age of 50 and 60, it also has a protective effect on your heart, and it may even have a protective effect on your brain. The other therapies don't have these effects as well. They just reduce menopause symptoms. So there are certain prescription medications, certain antidepressants that are used off-label to treat menopause. In the United States, there's one antidepressant that is prescribed for the treatment of menopause, but we don't have that molecule in Canada, so we use off-label several antidepressants. There's a medication that is used for convulsions and epilepsy that has very good effect on night sweats. It's taken at night to prevent night sweats. Cognitive behavior therapy has been proven to be very effective. And the problem with that is we don't have enough therapists providing care for women in menopause. But there's some books. There's a book written by a psychologist in UK that I read a few years after suffering from terrible hot flashes, and just reading that little book about cognitive behavior therapy helped me put up with the hot flashes much better than before. So it's not going to reduce your hot flashes, but it's going to change the way you go through them. So it's very, very helpful. Just like some other cognitive behavior therapies for insomnia are also helpful. Hypnosis has also been recommended, and it's effective. So there's a new North American Menopause Society position statement on
Yes.
non-hormone treatments that just came out last month and May 2023, and those things are there. What is out of there now is pregabalin, which was used before because of concerns with potential abuse, and also the old friend that so many women use, the clonidine, because it has a lot of adverse effects. There's a new drug in the States, oxybutynin in slow release, that we don't have in Canada, that is apparently very, very good for reducing hot flashes, and it's non-hormonal. But I don't know if or when we ever get our hands on that, but I'd love to see it in Canada.
Wow, that's very interesting. I didn't know about those last two there. That's really interesting. And what about topical treatments? Because we do have, excuse me, we do have oral treatments, but there are also topicals, and we can talk about topical estrogen. There's also this whole area of bioidentical hormones. Could you give us some insight on that? Because I feel like there's a lot of confusion around this area.
Yes, that is, because there's no uniform description for bioidentical. So different people, different societies define bioidentical therapy differently. Because it became so popular, was something that filled the gap after the WHI trial, was bioidentical therapy with all these risks associated and all the confusion. But these days and age, because it's not going away and women are not going to stop talking about it, societies like the endocrinologists of the United States and the North American Menopause Society, they decided to define bioidentical hormone as a hormone that is chemically, structurally similar to the hormones we made pre-menopause. So we had to find a definition. So that's the definition. If it is a chemical structure similar to what you produced, we can call it bioidentical. I prefer the term that is body identical, but they decided bioidentical. In any case, we have, when some people think about bioidenticals, they think that they're having a product compounded in a pharmacy made of yams just for them, a special compound that has no side effects, that is going to treat their hot flashes and not give him any problems. That's not the case. So if we're talking about bioidentical and it's a hormone similar to what you produce, we're talking mainly about 17 beta estradiol, which is the most common estrogen when we are in our reproductive year. And then we're talking about progesterone versus progestin. But people have to understand that there's no hormone growing out there that you can just bring home, infuse in water, or mush and put on. Hormones exist in our body. We produce them, but they're not in plants or any other natural way. So everything has to be chemically manufactured or adjusted in the lab before it can be used by a human being. And in Canada, we have many bioidentical products approved by Health Canada, and in the States approved by FDA. So we don't need to go and spend a lot of money trying to get something compounded just for us because it's a bioidentical. They are products that have been studied and approved and are available with a seal of approval from our healthcare Canada.
That's a great explanation, because I know that that's been a topic that there's just a lot of confusion about it, right? And there's
Mhm.
a lot out there. In regards to hormone replacement therapy in a woman who has a family history or history herself of having cancer, how should this be approached? I mean, generally, obviously, this is very specific to the circumstance, but is hormone replacement therapy ever an option, or do we need to look at more of
Menopause
these?
hormone therapy is not contraindicated in the woman who had not had cancer. So there's no reason not to prescribe menopause hormone therapy for someone with a cancer history in the family. And when I see my clients, one of the things I always make sure of is that we do assessments. We use Canadian tool assessments for to discover what is your risk of osteoporosis. Because if you have a high risk of osteoporosis, a low risk of breast cancer, and very bothersome menopause symptoms, and you don't have any contraindications for hormone therapy, then it might be a good thing. And we know from studies and from the results of the Women's Health Initiative that taking hormone therapy for 3 or 5 years does not increase the risk of breast cancer. So we need women to be educated so they can make a decision. As to be decision making has to be based on evidence and on facts, but women need to know what they are because everything has risks. We know Tylenol has side effects and has risk. Everything has risk. Everything we put in our system is going to affect us. So if you know before you take any hormone therapy, if you know if you don't have any contraindications, if you know that's going to help you fight or avoid, prevent osteoporosis, if you don't have a high risk for breast cancer, therefore you can introduce hormone therapy without being worried about it increasing your risk. Um, it's a good option for women. So unless you have actual history of cancer, otherwise it's not a contraindication.
Hmm. And as far as age goes, I've heard that over the age of 60, this generally wouldn't be recommended, but younger, it's
Yes,
more
so
helpful.
as I said in the WHI trial, they had a lot of older women when they
Yeah.
studied just the population who are going through menopause, the women between 50 and 60, who are usually going through menopause and experiencing the symptoms. Uh, the risks for those women under the age of 60 who are otherwise healthy, the benefits of hormone therapy outweigh the risks. So that's what all the experts say. If you take it for management of symptoms and you're under 60 and you are a healthy woman, the benefits outweigh the risks. And once you start hormone therapy, you don't have to take it for the rest of your life. So most of us know that the symptoms are worse for a few years and then they go down. You get less hot flashes, you're able to sleep again, your cognition seems to improve. You may want to take it for 3 or 5 years and then stop, and then you don't have to. You can cope with whatever symptoms you have. So it's a benefit for many women, and it would help many women not quit their jobs, for example, because they can cope with the symptoms and all the stress of a full-time job and a full-time family and so on.
Yeah, and that I think that's really important in recognizing that it's, and it really sounds like it's that dramatic drop in estrogen that's causing this. So if you can kind of, are you just trying to kind of level that out so the
That's right.
person
Instead
can,
of going like that, you go like this and you feel much better.
yeah, and that makes total sense. Is there ever any place for monitoring the serum concentration of these hormones? I actually had this question, I think, from a pharmacist recently as to like it, whether there's a perfect range or whether it's just very individual. Is there any point in monitoring this?
So if you think about doing tests to see how much estrogen you have in your body, in your system, in your blood, in your serum, think about what we just described perimenopause to be. It's a fluctuation of hormones through many years. So one day you test and your levels are high. The doctor is going to say, oh, your levels are high, you're not in perimenopause. Next month you test and your hormones are low. The doctor says, oh, you're menopause because your levels are low. But you don't know when you capture this in your cycle, when you capture this test. So unless you test every day for a whole month to see where you are at, it's not going to be an accurate result for your amount of estrogen on any given day. And besides that, so testing is not accurate. So why base a diagnosis on testing? What you're going to do with the number you're given?
Right.
If there's no outcome from knowing something, if we're not going to change the therapy or the approach to treatment based on a number, there's no point wasting money, wasting time, right? So most experts say we don't need to know what your estrogen levels are. What we need to know is what symptoms do you have? Are they caused by any medical conditions, or are they caused by perimenopause? You have hot flashes, night sweats, you can't sleep because you soak your pajamas every night, and next day you can't work and you yell at your kids. That's what we need to manage, is the symptoms and how they make you feel. We need to manage your quality of life. And if menopause symptoms are decreasing your quality of life, affecting the way you work, affecting the way you behave, then you do something about it. It doesn't matter what your level of estrogen is.
Mm-hmm. Mm-hmm. That's a really good explanation. And some women, we had another question about perimenopause and heavy cramping, heavy bleeding. Is this, and even bloating, is this common? Is there anything that women can do to help cope with this?
So one very common symptom in perimenopause is changes. As we said, it's usually the first change that we notice is changes in our periods. And some women go on to bleed for 3 weeks at a time, very heavily. I know women who would not go to work because in the days where we had to go to work and can work from home, which is another good thing for this population. Working from home makes it a lot easier because you can control the thermostat. You don't have to worry about finding a washroom nearby soon enough. There's a lot of pluses for working from home in perimenopause. You can take a nap at lunchtime. Anyway, yes, so some women bleed a lot heavier, and many of them develop anemia at this time of their lives too. And one of the first line treatments for this is a intrauterine dispositive or device with
Yes.
progesterone or progestin, because it helps to reduce the bleeding and eventually stopping it. And that may have beneficial effects in your anemia and your quality of life as well. So that's something that is a lot more common than we think, because again, we don't talk about menopause, so we don't know what women are going through.
Mm-hmm. We don't talk about menopause, but we do now, and we've had enough, right, Teresa? And I think it's really important for women who are listening to understand from this conversation that they do have options. There are solutions. You don't have to just suffer in silence, and there are people like Teresa out there that can help you. Teresa, could you? I mean, there must be some really common misconceptions or things that really alarm you about information women are given about this transition, or things that you often hear that you'd like to maybe warn women about, or things to stay away from. Is there any kind of messaging that you'd like to get out there to the world?
So the first thing I tell everyone who's listening or watching or thinking, am I in this position? If you've been wondering what it is, if you don't feel right, if you've done all the tests and your doctor says, oh, you fine, there's nothing wrong with you, but you don't feel right, investigate and see if it is perimenopause. And talk to your friends about it, because if we want to normalize menopause and have adequate education and support and means to deal with it, we need to talk. And women have to stop being embarrassed about talking about menopause. You can't go around whispering menopause. That's not going to change the world. It is upon us to talk about this. It's an issue that is impacting us directly. but also all of those indirectly around us. Whoever we live with, those who love us, live with us, work with us, everyone is impacted. Remember my mood swings? My family was going crazy with that. So we need to talk about it. We need to normalize it. And I want women to not feel that they are alone. There's a lot of us going through. It's not only you, it's all of us. And together we can make things better. And the other thing is, do not suffer alone. If you don't feel right, keep looking, keep searching for someone who can help you with this. Create if you know another woman who's finding herself in a workplace, create a network inside your work and talk to each other. See how you can change things in a workplace. Get a lunch and learn about menopause so your managers know what you're going through without you coming out and being stigmatized or whatever. So keep talking about menopause. It's a natural phase of life. You don't have to suffer through it. And the more help you get, and the more support from others like you, from your family, from your healthcare providers, the easier it will be to go through this phase. And then life will be beautiful after all.
Thank you for giving us that message of hope as well. Teresa, you have a wonderful newsletter. You're very active on LinkedIn. That's how I found you. Can you let people know how they can reach out and how they can find you for more information?
So they can connect with me, follow me, ask me questions on LinkedIn, Teresa Isabel Dias. They can sign up for my Menopause Ed newsletter on my website, menopaused.org. So menopause with a D at the end.
Thank you so much. And we will leave those links in the description of the video as well. Teresa, you're a ray of light and you are really changing the conversation surrounding menopause, right? So the changing the world starts one person at a time. And I really am grateful that you are a pharmacist who is doing this really important work. And so we'll continue the conversation and do reach out to Teresa if you do need more support for yourself or for your workplace or for anyone you know, and share this conversation so we can change the message surrounding menopause.
Thank you.